Assalamualaikum guys. Now we are talking about the reactions commonly seen in the survival of the terrorist attack. Why me? Why not him? I want to visit the site. I want to bomb them. I have a reason. Nothing can be done. Leave us alone. I don't believe their versions. They are partners with the agencies and the West. I do not want to live there anymore. I do not want to offer prayer anymore. I want to join the army. Now, how can you manage it? We will talk about first of all the medical illness that they are facing from. The terrorists are known to experience the paranoid anxiety, heavy magical thinking, omnipotent denial, grandiosity, and massive depression at the same time. They are often highly intelligent, sane, very focused, and have no indefinable psychopathology. It is therefore inappropriate to consider them sufferers to a clinical disorder. The trait and behavior pattern of them are closer to those hardened criminals and than patient. To label them psychotic stigmatize patient of the psychiatric disorders. What are the management consequences? Psychological trauma consequent of a terrorist act is often ignored while the physical trauma and disabilities draw most attention. Extensive research on the subject shows that one-third of the uninjured survival and two-thirds of those injured in terrorist attack are likely to develop long-term disability psychosocial consequences. Some key areas to be addressed include mobilization from the psychological trauma teams in the way as health professionals are trained to respond to the injuries. Trained teams, professionals need to be performed to address psychological trauma. These teams need to operate as first responders. They can be formed by training volunteers, rescue worker, ambulance staff, including the ambulance drivers, disaster relief worker, emergency health personnel, social worker, and hospital staff. Integration of psychosocial care with the surgical care. It is important to sensitize and train the surgical team members in the psychotrauma and its management training in the use of the effective communication skill, empathy, and awareness that fear and numbness can act as aggravating factors in the perception of pain and reaction to injuries can help its management. Linking up the survivor and dead with the families and unit centers. The biggest social support in response following activity comes through help in establishing the contact between the survival of the act and their families and loved one. In the chaos that sets in the aftermath of such an act and anguish of not knowing whether you love once are safe leaves a lasting impact. The longer it takes to re-establish the contact, the more traumatizing it is for the family and friends as well as survival. Exact, reliable, and valid information on the injured and dead is recommended from a behavioral sciences perspective. The strategy of gradually break bad news by initially announcing that no details are available, followed by the statement like has the serious injury but will be all right. We are trying to save them for those who have been martyred in the attack is counterproductive. Breaking bad news sensitivity and clearly about those injuries are martyred is as far as more appropriate approach. The news should, however, always be broken by somebody responsible and senior in the hierarchy. This helps the family and loved ones overcome their initial shock, numbness, and denial reactions. Updating in the case exact information about the lost injury and death is not available. It is important to not leave the affected families unattended with the crowd, media, and irresponsible people often lurking outside such things. The intermittent updates of the regular, clearly identified intervals and fixed timing by a nominated representative of the disaster management authority are the concerned agency that can help the confusion that prevails. Thank you so much.